Good morning, students. We shall now be continuing with an important topic. A 40-year-old female presented to the medicine OP with history of loss of weight and evening low-grade fever. She had complaints of cough with blood-tinged sputum. The X-ray showed certain features, and the sputum was sent for examination. The findings were: before I proceed further, I would like you to kindly note down this word blood-tinged sputum. Maybe towards the end we shall come back to it. These are the radiological findings, and this is some special stain that has been done. I will want you very much to find out what it is. And the diagnosis is tuberculosis. As we had said earlier, it can be any of these: an essay, a short note, a short essay, an MCQ, viva, practicals, a clinical case, and whatnot. I would like you people to find out if you can answer these questions well enough. Otherwise, see if you can at the end of the session. What is your diagnosis? Describe the gross on the microscopy. What are the probable lesions, complications, if the patient does not follow the treatment? And what are the different methods of diagnosing the disease? The topics to be covered in today's session are all these. Coming to secondary tuberculosis proper, only 5% of the cases of primary tuberculosis go in for secondary. Sometimes there can be a reactivation of a primary tuberculosis. Otherwise, a host is affected by a second infection when he is previously sensitized. These are two different things, and it will be clarified. And in some cases, there can be a reactivation of a dormant source. A patient would have had a primary tuberculosis, and later on somehow it becomes reactivated. It is located in the apex, and there is a high oxygen tension, as a result of which you find the organism gets localized in the apex of the lung. The lymph nodes are involved in secondary tuberculosis, but much later. And it is common in a patient who is immunocompromised. The common question will be, why does it occur in the apex? Look at this one. It's a classical lesion of a secondary tuberculosis. Initially, there will be an area of consolidation and there will be a caseous necrosis. But later on, what will happen is, when this necrosis erodes the bronchial tree, all the contents of the necrosis are emptied into the bronchial tree, as a result of which we will be getting a cavity. There will be a cavity that we'll see in a case of secondary tuberculosis. And these are certain other things we had seen in the earlier class. I'm seeing some patchy areas of consolidation. So there is a caseous necrosis. The cavitation erodes the bronchial tree, and sometimes it will be eroding the blood vessels also, as a result of which the patient develops hemoptysis. Finally, when it heals, there will be fibrosis. The lesion is usually about 2 centimeters or slightly more, and it is irregular in outline and it is about 1 to 2 centimeters away from the pleura. The cavity usually it is having a ragged margin. There are some cystic lesions which will be having a smooth margin, a hydatid cyst for example. But in tuberculosis, the cavity will be lined by a ragged margin. And these are the important lesions that we should be having in mind. There will be a consolidation, cavitation. There can be a tuberculous bronchopneumonia. I'll tell you what it is. Miliary tuberculosis, and finally, infiltration of the adjacent structures. We had seen this earlier. This is a diagrammatic sketch of the same one. You find that there is a Gons focus. When it becomes activated, it can ultimately end up in an apical lesion. So there is a consolidation, later on cavitation. Sometimes a patient has had an infection, he is sensitized, but then there is a secondary infection. He is reinfected with tuberculosis, and again the organism is localized in the apex because of the high oxygen tension. High oxygen tension. So this is the genesis of secondary tuberculosis. There are the other modes of presentation in tuberculosis. One is an endobronchial, endotracheal spread, which is called a galloping consumption. Second one is a miliary tuberculosis. Third is an isolated organ tuberculosis, such as brain, fallopian tube, bone, etc. There can be a pot spine, tuberculous lymphadenitis, and intestinal tuberculosis. So these are the other modes of presentation in tuberculosis. So be aware of all these. And look at this one. You find that it is a case of tuberculosis, but probably it has invaded the bronchial tree, etc. And it has spread throughout the lung. And there are patchy areas of consolidation which have been marked by the arrows. Suddenly I find that there is a rapid deterioration in the condition of the patient. And this is called a galloping consumption. The moment it invades the tracheobronchial tree, it becomes a thoroughfare. The organism can spread very easily throughout the lung or even to the opposite lung. The deterioration is called as galloping consumption. This particular diagram I would like you people to draw. So typically you find that there is a cavitatory lesion in the apex. Sometimes there can be multiple cavities. And why do you get a cavity? That is because of the erosion of the bronchial tree. The contents are drained into it. There is a residual lesion, which is the cavity. And also, I told you that there can be an erosion of the blood vessel leading to a hemoptysis. My professor used to say that hemoptysis in a case of tuberculosis can be the end of the beginning or the beginning of the end. Find out what it means. And again in secondary tuberculosis also, the hilar lymph nodes can be involved. This is a very nice and simple diagram. Any one diagram, in fact this will be much better, you can draw for a question on secondary tuberculosis. The complications of tuberculosis can be a tuberculous bronchopneumonia, we had mentioned. Bronchiectasis, we had seen in an earlier class, and one of the causes can be tuberculosis. Okay, it can spread to the pleural space, causing a pleural lesion called as empyema, or just an inflammation, a pleuritis. Miliary tuberculosis is very important, meningitis. That is what we are seeing here. It is a brain, and there is a basal matter that is covering it. And it is not transparent, it is opaque. That is because of the fibrinous exudate. So it usually affects the base of the brain. You can have a meningitis, pot spine, salpingitis, osteomyelitis, and pyelonephritis. These are the various complications of tuberculosis Please have them in mind. What are the differences between primary and secondary tuberculosis? A question in pathology, pediatrics, medicine, and whatnot. So these are the differences. Primary in children, secondary in adults. It is asymptomatic, whereas it is symptomatic, and there can be open cases of tuberculosis. What do I mean by the word open case? As long as it is confined, it does not spread. But once it erodes a bronchial tree, when the patient coughs, he can spread the bacilli easily. That is called an open case. Sputum is rarely positive, it is positive in secondary. You have got a Gons focus, then an Asman's or a Simon's focus. Subpleural nodule, whereas it is an apical consolidation. Non-infectious, and then it is infectious. Hemoptysis is quite uncommon in primary tuberculosis, whereas it is common in secondary tuberculosis. And these are the modes of spread. Please by heart this. It is a clinical difference. But then, what are the pathological differences? In primary, 1 to 1.5 centimeters subpleural, whereas it is 2 centimeter apex. So it gets fibrosed or calcified. Here you get a cavitatory lesion. There can be a tuberculous bronchopneumonia. Miliary tuberculosis is common in both. And there can be a pleural fibrosis, effusion, or an empyema. Granuloma classically is seen in both. Granuloma. And the investigations are more or less common. Sputum will be positive in the case of secondary tuberculosis. And it can spread to other organs. Please remember these differences. It will fetch you marks. So what next? Look at these pictures. I would like you to make a diagnosis. Find out the organs. What is your diagnosis? So this is a specimen of a lung and this is a spleen. And in both I am finding multiple dot-like structures, multiple small spots throughout the surface. Here also, it is there throughout the cut surface. So what is your diagnosis? Miliary tuberculosis. So why do you get this miliary tuberculosis? What are the types of the miliary tuberculosis? For that, I should be able to recollect the circulation. So this is a diagrammatic representation of the lung. So when there is going to be a lesion in the lung, these are the pulmonary veins. It goes to the left side of the heart, which is a systemic circulation. From the systemic circulation, it is an arterial circulation. It can go to any part of the body, including the lung. So this is called a systemic miliary because it enters the systemic circulation. Sometimes the bronchial vein, and then it can go to the right side of the heart. From the right side, you find through the pulmonary artery, it goes only to the lungs. So that is called a pulmonary miliary. So first is a systemic miliary, second is a pulmonary miliary. And if there is going to be a lymphatic drainage, that also goes to the right side of the heart, from the right side, pulmonary artery to the lungs. So what are the types of miliary tuberculosis? I should explain the spread. So one is the pulmonary veins, systemic circulation, systemic miliary, including the lungs. Two is lymphatics, right side of the heart to the lungs, pulmonary miliary. And bronchial vein, right side to the pulmonary structures. So again, it is called a pulmonary miliary. The word miliary means millet seed-like. It resembles canary bird feed. It is something that is used for feeding the birds. Hardly about 1 to 2 millimeters in size, not centimeters. They are yellowish and they are spread throughout the organ that is affected, separated by the normal parenchyma. So there is a normal parenchyma and specks of this miliary lesions. And microscopically, we will be seeing caseating granuloma. Caseating granuloma. Common sense is superior to knowledge because students generally miss this word granuloma. So describe the granuloma and you get the marks for it. All parenchymal organs, including the lungs, are involved in systemic miliary. Lungs are involved in pulmonary miliary. And these are the lesions. Multiple organs, lymph nodes, spleen, bone marrow, liver, eye, all can be affected. In tuberculosis, there are some organs which are resistant. That will be the heart, thyroid, pancreas. In these organs, we rarely get tuberculosis. Maybe because they are in a state of contraction or whatsoever. You do not get tuberculosis in these organs. And this is a summary of the tuberculous lesion. You can go through this flow chart leisurely. So there is a primary complex which can get healed or it can become progressive. From the primary complex, there can be a miliary tuberculosis. Similarly, there can be a secondary tuberculosis that is developing, which affects the apex of the lung. There can be progressive secondary tuberculosis, tuberculous bronchopneumonia, or a galloping consumption. And there can be a dissemination including miliary tuberculosis. It is a simple diagram provided you know the text. Kindly follow it, it will help you to recollect the answer. There is another entity called isolated organ tuberculosis. Sometimes patients come to the doctor with specific complaint, and then when they are examined, they find that a particular organ is affected. What are the organs which can be affected? These are a few examples. So that is a tuberculosis of the adrenal. Look at the extensive caseous necrosis. And this is an autopsy specimen of the TB spine. You find that there has been a collapse of the vertebrae and it has been taken from this author. A collapse of the vertebrae, typical of tuberculosis. And moreover, if there is going to be a live lesion, it can spread via the psoas muscle leading on to a psoas abscess. It does not have the classical features of inflammation, therefore it is described as a cold abscess. And you people should remember this. There can be apical tuberculosis. These are some examples of isolated organ tuberculosis. These diagrams you people can draw. Another organ that has been affected, it is the kidney. The kidney is almost totally replaced by necrosis. All this caseous and soft material or areas of necrosis, and this is the pelvic helix that is there. The organs that are affected are here. I have shown you some pictures. That is there. Fallopian tube, the common complaint is infertility. What are the lab diagnoses of tuberculosis? Lab diagnosis of tuberculosis, this is common to primary as well as secondary tuberculosis. So, a sputum for AFB, Zeal-Nielsen, and then the Oramin rhodamin stain can be there. These are the two stains which can be done for AFB. And Lowenstein-Jensen medium, X-ray of the chest, CT scan, ESR, FNAC if there is any lymph node enlargement. Today, polymerase chain reaction is the talk of the town. Biopsy can be taken from organs such as liver to rule out a miliary tuberculosis. And of course, CSF is mandatory in cases of meningitis. So this is an acid-fast stain and it's showing clusters of the tubercle bacilli. And this is your LJ medium. Can you tell me the period after which the culture is positive? Go back to your microbiology. And as a summary, these are the important things we have seen this. What is primary? What is secondary? What are the differences between primary and secondary, miliary tuberculosis. What are the lab diagnoses? And what are the isolated organs that are affected by tuberculosis? Granuloma and the diagram. So this is one picture that I would like you people to always bear in mind, because this can be drawn for any of these. If for any of these questions, this is a diagram. So it gives primary tuberculosis, secondary tuberculosis, miliary tuberculosis, tuberculous osteomyelitis, TB lymph node, meningitis, and caught spine. So it is common sense. And this is a very nice saying of the common sense. Common sense is something that everybody needs, few have, and none think they lack. Benjamin Franklin, an amazing author. So these are things that you people should remember. Efkaristo.